So this is an oversized sacrum here.
Nice.
So here's L4, here's L5, here's L5S1. Okay. Here's our sacrum. Okay. So I'm going to be looking for the sacral sulcus. So if you find L5, move across and slightly down. This is my sacral sulcus in here. Now, interestingly, what do you guys see on Liz in terms of her sacral sulcus? The right is deep. So what I will write down is that her right sulcus is deep. Okay, do you guys see that? Yeah. There's no doubt about that. I mean, that's right sulcus is deep on her. Okay. Then so I usually use my middle fingers or my index fingers to feel that. Okay, but that's dead on. That is definitely a deep sulcus on her right. Okay. Then I get to the ILAs, and I'm asking myself, okay, now is one ILA more posterior? It's either going to be posterior or inferior. That's what I'm looking for. So
how do you find the ILA?
The ILA, so I can kind of come down about 3 or 4 inches. Here's the coccyx right here, okay? Come lateral to that and start to push upward, and you'll feel bony tissue, okay? So it feels kind of hard. This is the ILA. Now, I would say on Liz, right sulcus is deep. And what would we say about this right ILA?
It's lower.
Inferior. It looks like superior to you, all right? Inferior to me. So her right ILA looks like it is inferior compared to the left. So I'm always documenting, in terms of ILAs, I'm looking for and documenting what's either posterior or inferior. So is it sticking out like this, or is it looking, what's more prominent, the posterior part or the inferior part? On Liz, it looks more like she is inferior on this side. Now, would that be synonymous with a sacral torsion? This is going to be more of what we're going to call a sacral shear or a side bent sacrum. And this is going to get confusing. When you have a sacral torsion, your findings are positive on opposite sides. If she had a sacral torsion, her right would be deep and her left ILA would be more posterior. Okay, so this is where I'm going to use the terms, are the findings positive on the same side or are they positive on the opposite side? And what I mean by positive on the same side, the sulcus, the deep sulcus, would be kind of positive, and the ILA that's more posterior or inferior would be positive. So if she looks like this is deep and this is posterior or inferior, then I would say findings are opposite sides. Okay, when you have a torsion, they're positive on opposite sides. Okay, so if your findings are opposite sides, you're dealing with a torsion. So what torsion would we have? If she looked deep here and more posterior on the left, which direction is her sacrum facing?
Right, yeah, left rotation.
Her I don't know the axis. All I know is her sacrum would be rotated left. Okay, so if she looked like this, she'd be looking like that, okay? So the sacral base and that ILA position, that'll give me the direction of torsion, okay?
So it goes towards the deep side, so they're going towards the right, it's left.
You could say that, yeah.
Because the left
Right,
ILA is
these are my eyes and I'm doing that.
Whatever's up, it's torsion. Oh, okay, now I get the point. Okay, there you go.
Okay? So that would be what a left torsion would look like. Whatever it's looking, or it's going to be side bent like this, okay? When she has a torsion, this is going to be deep, and this is going to feel more prominent on this side, okay? If she has what's called a sacral shear or a side bent sacrum, she's going to be looking like this. Now, if she's side bent to the right, she's going to be a little bit rotated left. So this is going to be deep, but this is going to be more inferior. So if I have a deep sulcus, I got to check out ILA position. If the ILA seems inferior here, then I'm dealing with what's called a sacral shear, meaning this is either sheared inferiorly or that is sheared superiorly, okay? It looks like it's side bent, all right? If findings look more like this, where this is more prominent and this is deep, so again, opposite, so it's kind of like which ILA is more prominent. And it's either going to be prominent posteriorly or it's going to be prominent inferiorly, okay? I'm not going to label which one feels superior.
So my increased lordosis, doesn't that put me in like a Sphinx test? So if I'm looking normal, like if you didn't even it out, couldn't
the question is just, why do you have an increased lordosis?
I don't know.
No,
no.
Because your sacrum is nutated.
Okay.
So this is an example of a flexed sacrum or a nutated sacrum. Okay, so you okay with that terminology? Her sacrum is bilaterally flexed or bilaterally nutated. Okay? How do we want to treat somebody like her? What's her motion restriction? Counter nutation. So I might treat her by doing a technique where I'm pushing, I'm doing this sort of thing to the sacrum. Okay?
This summer, I saw someone who had a disc issue, and we were doing a bunch of extension exercises. And she started complaining of pain on her sacrum. And then as soon as you did this, held the sacrum from nutating, pain went away.
Because she probably had a backward sacral torsion. That would be my guess. A lot of disc patients have sacral torsions. This is the other thing. These disc patients, very common. Think of what a sacral torsion does to your annular fibers of a disc. Okay? Totally. So I've seen plenty of patients with herniated discs a la MRI, and they come in, they have blocked extension, and you work on extension, and they hate it. They're like, this sucks. This extension hurts me. Well, then you look at their sacrum, and they have this backward sacral. People with backward sacral torsions, they don't like extension because it hurts. Because it just can't go. So this one keeps going, and that's going to hurt them. So if you treat their sacral torsion, they can then regain the extension and enough extension to kind of start to reduce the disc. So
You got both.
Oh, yeah.
Yeah.
That happens all the time. You guys need to be really open-minded with this stuff. Very commonly, disc herniations and sacral torsions happen together. Right to the ceiling for so this one, so the R, whatever the circle, that goes to the ceiling. So what I do here is I side bender, gently pull your feet to the floor, relax, I side bend her a little more. Pull your feet to the floor, relax, I side bend a little more. I'm not rotating. I'm only doing the side bending. For when you're doing corrections for neutral lesions, you're only side bending. And if you think about it,